Well, good morning, everybody. Good morning. Good morning. Good morning. For those of you that don't know me, people might be visiting. I'm Ellen Hartenbach. I'm the chair of OBGYN, and I love being in this conference room because, Meritor donated the money for this particular conference room, and it shows how connected we are with Unity Point Meritor. But today we're going to focus on our research programs, and I really like that we have well, we have more than one day each year, but we at least have one day each year where we can shine a light on the array of research programs in the department, wide-ranging and just high level of expertise. I mean, we're a highly ranked department in a world-class university, and research is really one of our core missions, always has been all the years that I've been here. And yet it's challenging, right? It's like super challenging right now, but we are not going to lose our way. We are going to keep pushing forward and putting our research programs front and center. We have to dip into a little reserves, but we are going to keep working on our research programs because it matters. And I was reminded yesterday, actually Tuesday morning, about how much it matters. I have an ovarian cancer patient that I did her surgery on 15 years ago, and then she's had no less than 4 recurrences all over her body, including in her liver, and 3 different things have made her where she is today, which is no cancer, 0 cancer. She asked me, can you do something to get me to live till my last son leaves high school? Well, that son's out of college now, and he is actually, he's getting married this fall. And I'll just tell you, it's 3 things, because Avastin was a brand new drug. We weren't really using it in people. She wanted to get on the trial right away. She did that for 2 years between 2010 and 2012. And then a couple of years later, when it recurred in her liver, it was small enough that we could use radiofrequency ablation, something the interventional radiologists do. We hadn't been doing that 15, 20 years ago. And then she was like, okay, keep me going until something else is discovered. Well, PARP inhibitors have just changed the face of ovarian cancer. And so the minute she was eligible, the minute the FDA approved it, we got her on a PARP inhibitor, and now she's where she is today. So I really believe that our patients, our communities, our families, our nation needs fundamental research. And we need it like we need water and the air we breathe. So with that, I'm super excited to welcome you to Research Day. And I want to, point out a couple of housekeeping things. So our code today is YOD. So write that down and sign yourself up. And then I also need to thank a few people, because Research Day is something that takes a lot of planning. And really, the people putting their time into Research Day are our research vice chairs, Dr. Manish Patenkar and Dr. Kara Hoppy. I thought I saw Manish. Come on, wave up. Round of applause for Manish. And Kara, you're in here somewhere. Kara Hoppy, where are you, Kara Hoppy? She's on her way. Okay, well, when you live over at Unity Point Meritor, parking at the university's hospital is not so easy. But congratulate Kara when you see her. The planning committee, we can't do any events without these people. They are amazing. Jamie Reitz and Autumn Hayes, yay. And the administrative support, that they are the wings behind everything that happens in this department. So Stephanie Eggers really has helped out with this particular group, and Elizabeth Albert, who really is a high-level administrator in the department, doing a lot of behind-the-scenes work in our research enterprises. So another round of applause for those 2. So now I can turn it over to Dr. Alex Stanek, who is one of our research stalwarts, made tremendous contributions in his time here at UW. And in his ASRM circles, he got to know Dr. Pisarska, who she just told me was a friend of Laurel. So, there's so many people in the country that are friends of Laurel who have heard about our university. We're so excited she came from California, and she's going to enlighten us with her keynote speech. And then we're going to really hear a lot from the people in the department about their ongoing research. So I'm going to turn it over to Alex, and I can't wait to enjoy the morning.
Well, good morning, everybody. It is a rare and wonderful delight for me to introduce Dr. Pisarska today. And in many ways, I think her career and who she is can be summarized with the following. She's a New Yorker ruling LA. And that, I think, kind of gets the synthesis of who she is, because she has been beyond a triple threat in academia. I feel like for her, that should be entirely considered passé. Maybe a better way to put it would be an exponential threat, because that is really the way that she has approached the broad aspects of our field. She has been an incredible and continues to be an incredible mentor. She's an incredible scientist, and we're going to hear a whole lot about that today, and specifically at the intersection of reproductive endocrinology and then MFM and pregnancy. And really, that is the way I think our entire field should be thinking about where we are and where we need to be in the future. She serves as the director of the division of REI at Cedars-Sinai. She serves as the lead IVF director at the same center as well. She's the professor at Cedars-Sinai. She's a professor in residence at UCLA. And that's just the titles. I have actually considered getting a bibliometric consult from our library, because her CV actually probably needs a table of contents rather than just a list. And given all of the things that she does, including having served as the director of ABOC and being on the board of directors and supporting fellows and learners, from the time that actually all of us were fellows, Dr. Cooney was just sharing last night about the first time she met Dr. Pisarska was on a boat during one of our fellowship retreats. And that's who Dr. Pisarska is. She is an incredible scientist, incredible REI, an incredible OBGYN who is pushing this field forward. And with that, please.
Thank you. Thank you so much. Can you hear me okay? Awesome. All right. Well, thank you so much for that wonderful introduction. And just to echo, I'm really excited to hear about all the research that you are doing in your department today. And I always think of it that it's just so important to push our field forward and always to stay curious. And if you have a question, you have to just move forward and find a way to solve that and come up with an answer or solution, because it's really our patients that we serve that we really want to help and help them succeed in their health care. So I have no disclosures, and I'll be talking about things that we're currently doing that is maybe not yet fully published, but and I will not be speaking of any unlabeled or unapproved drugs or devices. And our learning objectives for today will be to identify types of adverse pregnancy outcomes associated with infertility and treatments, to define the contribution of the placenta that leads to adverse pregnancy outcomes, define how the underlying infertility and treatments impact placentation to better understand their roles and overall outcomes, and lastly, discuss some of the newer scientific tools and developments and models to study the role of the placenta. So we know that infertility affects 1 in 6 people globally. And the different treatment options include ovarian stimulation with intrauterine insemination, where fertilization takes place in the reproductive tract. This accounts for about almost 5% of live births in the United States. The other option includes in vitro fertilization, or IVF, where gametes are manipulated outside of the reproductive tract in the laboratory and embryos develop within the laboratory. This accounts for about 2% of live births in the United States, and over 8 million babies have been born worldwide as a result of IVF. So what we've been largely focusing on, and questions we had, and how all of this research evolved, was to determine if there are differences in these pregnancies that conceive through couples of infertility versus spontaneous conceptions. And some of the earlier work that we did, we found, as others have, is that we do see significant differences in maternal age and race between fertile and infertile couples. We see increased risks of cesarean deliveries in pregnancies conceived from couples with infertility, and conceptions from infertile couples deliver earlier. We also looked at a group of individuals known as the VAMA, or the Very Advanced Maternal Age Group, which is women who were over the age of 45, because we found that that was a pretty large population in LA. And when we looked at pregnancies that conceived through assisted reproductive versus those that conceived spontaneously, and surprisingly so, we did have women who were getting pregnant over the age of 45 without our assistance. We also found that the ART pregnancies, or assisted reproductive technology pregnancies, were still significantly older than those that conceived spontaneously, even above 45, more likely to be white, as well as nulliparous. They also continue to be at increased risk for cesarean delivery, and they also had an increased risk of a placenta, a retained placenta. And so that was part of where we started to think that maybe the placenta might be playing a role in some of the outcomes that we were seeing later on that I'll discuss. So we do know that pregnancies conceived with infertility and fertility treatments are at increased risk of certain adverse outcomes. And so largely people have been focusing on those that conceived with IVF because of the concern of the gametes being manipulated outside of the reproductive tract, which includes gestational diabetes, pregnancy-induced hypertension, placenta previa, preterm birth, postpartum hemorrhage, small for gestational age babies, and perinatal mortality. However, these studies were largely studied comparing to spontaneous conceptions. But when we look at non-IVF fertility treatments, so that's the ovarian stimulation with intrauterine inseminations, we find that these risks are also increased, including gestational diabetes, pregnancy-induced hypertension, abruption, low birth weight, and perinatal mortality, suggesting that it's probably the underlying infertility and not the fertility treatments that are contributing to some of these outcomes. So we also looked at maternal morbidity, and we looked at significant maternal morbidity, which we used the gold standard guidelines of what true SMM cases were, which includes hemorrhage, hypertension, renal complications, pulmonary and cardiac and cardiovascular events, surgical complications, and anesthesia. And what we found is that there were a higher rate of women utilizing fertility treatments had significant maternal morbidity compared to those that did not have a history of infertility. This was also looked at in an insurance claims database where they looked at over 500,000 individuals. And what they found is that any severe maternal morbidity, including the morbidities that are outlined here, was associated just with a diagnosis of infertility, suggesting that, again, it is not necessarily the treatments, but there might be some underlying factors. So what about the infants? And so we and others have also demonstrated that there is a higher rate of preterm deliveries. And not only is there a higher rate of early preterm, but also what we call late preterm deliveries. And so that's at the above 34 weeks, but those individuals also have higher NICU admissions. So again, there are factors contributing to that as well. And then birth defects was something else that there were a lot of studies, and this is one of the earlier studies that was done looking at birth defects. And largely it was related to whether or not IVF increases the risk. But after adjusting, the use of IVF did not necessarily increase the risk of birth defects. There was a slightly increased risk with the utilization of something called ICSI, or intracytoplasmic sperm injection, where the sperm is directly injected into the oocyte, and that it was largely done previously for male factor infertility. And the interesting thing is utilization of clomiphene citrate alone also significantly increased risk. And there was a recent paper that just came out that's in press that you might have seen through your ACOG news that comes out through your emails, also suggesting that. And then even pregnancies that conceived with a parent who had a history of infertility had an increased risk than just IVF alone. More recently, this was also found to be consistent. And when they looked at all birth defects, if you see here that on the top here, these are siblings who conceived spontaneously of parents who had a history of infertility and had another child that conceived with assisted reproductive technologies. The other thing that came out of this study also demonstrates that obviously age increases risk of birth defects. And as we talked about, age is one of the factors that women who undergo infertility treatments are more likely to deliver at an older age. And this alone might also be contributory to some of the outcomes we see. However, the good news is despite these increased risks of adverse outcomes, the overall incidence and relative risk of these outcomes is low. When we look at how much earlier babies deliver following IVF, it's really only a half a day earlier, and birth weight is only 33 grams lower. So not really something that's super concerning. So overall, these babies do quite well. There's also been a lot of discussion about DNA methylation and imprinting disorders, and this is what really drove some of the work that we did and are currently doing to try to identify risks associated with that. So we know that maternal morbidity is associated with the diagnosis of infertility regardless of treatment. Adverse outcomes are associated with both IVF and NIFT. Congenital anomalies are associated with the underlying infertility, and even some studies show that time to pregnancy increases risk of congenital malformation, and we know that infertility treatments tend to increase the time to pregnancy, but it's probably a product of the infertility. The thing is that many models that have been used to study the effect of IVF do not always include an infertile cohort and have traditionally studied IVF pregnancies to spontaneous conception. And then when we looked at all of these different outcomes, they all seem to be related to placentation defects, and that's what caused us to really start focusing and honing in on the placenta. So that is where my first big curious question came a number of years ago, because technically I was an ovarian physiologist studying transcriptional regulation, but this became something that was really important for me to try to study and understand. So we tried to look at whether these outcomes are associated with ART and the IVF process or the underlying infertility. And there was a study that was done a number of years ago where there was a big splash that Beckwith-Wiedemann syndrome, and one of the imprinting disorders, there was a higher prevalence in IVF and IVF with ICSI, and there were a number of case series and surveys that were conducted that suggested it. Most of them were through registries, so again, a lot of potential recall bias. And when they looked at some of the cohort studies, when you really look at the numbers, because it's quite rare, there was only one case of Beckwith-Wiedemann syndrome among almost 25,000 individuals who were born through assisted reproductive technologies compared to those that conceived spontaneously. So why this has been something that's been looked at and people have been trying to understand is whether or not the steps associated with IVF might subject embryos to stress. That includes the egg retrieval, the in vitro fertilization, the intracytoplasmic sperm injection, and the micromanipulation of gametes. And there is, of course, data that we know that imprinted genes are expressed during the human pre-implantation period. They may be more sensitive to disruption by environmental factors. And ovarian stimulation with gonadotropins may cause DNA methylation and gene expression differences in some of the imprinted genes in the oocytes. There have been some animal studies that show that IVF and embryo culture media may be associated with epimutations. And when all of this was coming out, this really led us to start thinking about how should we do this and what should we do. The other thing that came out as well is at term, individuals were looking at DNA methylation in children conceived with in vitro, and again, focusing on those conceived and comparing them to spontaneous conceptions. But really, the term placenta and cord blood may not necessarily reflect these early changes that occur as a direct result of the IVF conditions in ART. And that might really reflect changes in the intrauterine environment, which may be altering the fetal epigenome, leading to gene expression changes. So we really needed to get closer to the time of conception to better understand how this is impacted. So there was a study looking at in mice that placental weight and fetal weight to placenta weight ratio may be different. And so we looked at that initially, and we found that there was no difference in when we looked at humans, and we looked at placental weight, birth weight, and birth weight to placenta weight ratios. But the interesting thing is we still see some inklings of the placenta playing a role, and there was a higher rate of placenta accreta in the infertile population compared to the spontaneous population. We also did linear regression, and we looked at placenta weight, fetal size, and fetal size to placenta weight ratios across gestation. And when we look at the different pregnancies conceived, those conceived spontaneously in red and green versus those conceived with non-IVF fertility treatment and those conceived with IVF in red, we do not see any differences in placenta weight or birth weight across gestation. So other studies have suggested that abnormal placentation, which is associated with the adverse outcomes of PIH, preeclampsia, gestational diabetes, previa, abruption, and retention, may be due to some of the biochemical factors and other histological factors, such as abnormal placentation, abnormal placental morphology, and protein profiles. So to take us back to placentation and the placenta is made up of various different cell types, which includes the villus cytotrophoblasts, which are the undifferentiated precursor cells. And then that leads to differentiation into what's called the extravillus trophoblasts that invade the decidua and the maternal blood vessels. There's also the syncytio trophoblasts, which facilitate nutrient exchange and produce hormones, as well as endothelial cells that line the fetal blood vessels, and various different immune cells, including some stromal fibroblasts, dendritic cells, macrophages, and Hofbrauer cells that are present at the time of placentation, which is in the first trimester. So fortunately, I was very lucky, and I transitioned from studying the ovary to studying the placenta, and largely because we had a large chorionic villus sampling program with John Williams, where he would do 2,000 chorionic villus sampling for genetic testing a year. And we figured we should capitalize on this, and this is an opportunity because nobody has really looked at that when we started doing this work. And so they do chorionic villus sampling for prenatal diagnostic testing at about 11 to 13 weeks. And the great thing is that these will be ongoing pregnancies, so we could look at these pregnancies and see how they develop when we use some of the leftover discarded tissue. And not without a lot of, sweat and tears that it took us to even try to figure out how to isolate a lot of RNA, which would degrade from about 5 milligrams of leftover tissue, but ultimately we were quite successful. And the reason why this is so important, and it was really critical for our studies, is this was the earliest time point to look at placentation from pregnancies that are conceived either spontaneously or with infertility and assisted reproductive technologies in order to better understand what's happening early. And then we also look at cells at the time of delivery, and it sort of gives us a snapshot of the intrauterine environment to help us understand what outcomes we would see and expect. So we first want to make sure that there were no differences in cytogenetic abnormalities between spontaneous conceptions and those conceived with infertility, and we found that there was no difference. And we also divided them up into those that conceived with what back in the day we called in vivo fertilization, which is NIFT, versus in vitro fertilization, and again, no difference in cytogenetic abnormalities. And then we delivered our SMART cohort, which was a cohort of pregnancies that conceived either spontaneously or in couples with infertility who conceived through non-IVF fertility treatment or IVF. They were enrolled at the late first trimester following chorionic villus sampling and followed till delivery. And that consisted of about 200 spontaneous conceptions and 200 conceived with infertility, half with non-IVF fertility treatment and half with IVF. And so we wanted to start to look at how placentation affects outcomes and implantation. So the first thing we did is we started to look at gene expression changes in the chorionic villi. And interestingly, out of about 62,000 genes, when we conducted RNA sequencing, we only found one gene that was differentially expressed between the spontaneous group and the infertile group, which is a calcium voltage-gated channel subunit alpha-1. And interestingly enough, this was the only gene that was differentially expressed between the spontaneously conceived pregnancies and those that conceived with IVF. Interestingly enough, when we compared our NIFT versus our IVF conceptions, we found 5 genes that were differentially expressed. And the interesting thing that we found is that the spontaneously conceptions ended up actually closer, the gene expression was more consistent with those who had IVF than those that conceived with NIFT, shown here in blue, suggesting that maybe the population of our NIFT conceptions was a little bit different, and largely many patients who have PCOS will likely succeed with non-IVF fertility treatments to conceive. So then the next thing was the epigenetics, and this is about all of the studies that were focused on epigenetics and methylation changes that are due to the media as well as to the environment in the laboratory. So what we did is global methylation, and we looked at over 850,000 methylation hits that we look at on the DNA to see if there's changes in methylation that then ultimately leads to changes in transcription and changes gene expression. And so when we looked at the global methylation overall, this is a principal component analysis, and what we look for is clustering of different populations to see if they cluster away from each other. And what we see here is when we look at the unassisted pregnancies, which are shown here in green, versus the non-IVF fertility treatment conceptions shown here in blue, and the IVF conceptions shown here in purple, they do not cluster at all. They all seem to merge, and we don't find any specific patterns. We also did median beta values, which is another way to look at it. And we did see that there was changes in mean methylation levels between the spontaneous and the infertile population. So there was lower methylation overall in the infertility cohort. But when we compared and broke out the non-IVF fertility and the IVF conceptions, we no longer see a difference. So again, it's more consistent that probably the infertility is the contributory factor. This is a heat map, and what we did is when we looked at all of these different methylation hits or changes in the methylation, or what's known to be the CPG sites, and it's a computational system that isolates where these different CPG sites are methylated to help us look for, again, more detailed clustering based on where the sites are methylated. Interestingly enough, what we found is unassisted conceptions, or those that conceived spontaneously, cluster together, and those that conceived with infertility also cluster together. But then when we try to see if IVF or NIFT separate out, we don't see that. So it's a more homogeneous, a heterogeneous population in infertility. So it doesn't suggest that there's a divergence depending on the type of fertility treatment. So when we looked at the individual probes, so this is again out of 850,000 probes, we see that there's only 185 probes, or less than 0.1% or 0.02% of probes that were differentially methylated between the spontaneous versus infertility. And this is basically what we call a Manhattan plot. And what it does is it shows us on all of the different chromosomes locations of where methylation changes occur. And the more different they are, the higher up they are shown here. And when we look at Bonferroni correction at 0.05, we only focus on the ones that are significant. And so we didn't find anything that looked like there was hotspots along different chromosomes as well. And that's why we map it out on these Manhattan plots. When we looked at spontaneous versus NIFT conceptions, only 28 probes were differentially methylated. The spontaneous versus IVF was about 195 probes were differentially methylated. But interestingly enough, as what we're seeing as a trend is that those that conceived with NIFT versus IVF, there's only 13 probes that were differentially methylated, suggesting that that group is a much more similar group compared to spontaneous conceptions. We also looked at whether or not this methylation led to gene expression changes as well, because that's what the premise is methylation regulates how our genes get expressed. And when we looked at the differentially methylated probes, those that conceived spontaneously versus those with infertility, only 15 of them led to some gene expression changes in the first trimester placenta, only 2 in the non-IVF versus spontaneous conceptions, and 18 in the IVF versus spontaneous conceptions. And those 13 probes that were differentially methylated didn't lead to any changes in the IVF versus NIFT conceptions. So the thought has always been that differential methylation is something that's going to, particularly of imprinted genes, is going to stay consistent throughout our lifetime to lead to change overall. But methylation is also so dynamic, and we know that so many environmental factors contribute to it. So we wanted to look at methylation changes across the lifespan, and we did a systematic review of our studies as well as various other studies that were done looking at fetal tissue, term placenta, cord blood, newborn dry spots, childhood blood, as well as peripheral blood from adults of various different types of conceptions. And what we found is that, and this is very busy, but what we did is we mapped across all of the chromosomes the differentially methylated hits. And just to blow this up a little bit, when we compared these differentially methylated genes and looked at whether or not across the different studies and across the lifespan, whether or not there was any individual methylated sites that were consistent, we actually found very, very few. Even in some of the studies looking at cord blood, for example, that were from different studies and populations, did not really have differential methylation across multiple studies. There was very few. And there was one differentially methylated gene that is imprinted. So again, very rare and not consistent with what we might be seeing in some of our animal studies. So then what about the genetics? And so what we did is we did a family-associated GWAS, or genome-wide association study, where we take single nucleotide variants. So these are variants along your genetic makeup, and everybody has them. And they can associate with various different diseases, various different phenotypes, and that helps us better understand what might be contributing to some of the outcomes we see. And so when we looked at this single nucleotide variants or the gene expression, the gene changes and or the DNA changes, excuse me, and the nucleotides, we didn't find any SNPs that were significant on a genome-wide significant value. Of the 637,000 variants, we did find 11 variants that were identified as subgenome-wide significance that represent 5 different loci. And then when we did something called a EQTL analysis to look at where these different variants might associate with different tissues, and in the large data sets, they don't have one for placenta, so we can't really focus on that, but we also did see that 3 of the transcripts that we found might associate genetically are found in whole blood and adipose, suggesting maybe, again, there could be also an inflammatory process that's contributing, or in adipose, we think of other factors and how obesity can contribute to infertility, particularly PCOS. So then what about the environment and the fertility treatments? So supraphysiologic hormone levels have been implicated to increase rates of low birth weight and small for gestational age babies. And since pregnancies conceived through fertility treatments are exposed to elevated estradiol and progesterone levels, either endogenously through treatments or exogenously to supplement the pregnancy, we wanted to determine whether previous treatments impact the hormonal milieu on the ongoing pregnancy. So we looked at hormone levels in the mothers further out from the time when they were receiving supraphysiologic hormones. So this was again at 12 weeks. This is after they've discontinued supplementation. And what we see is that estradiol levels remain elevated in the infertility population, as well as progesterone levels. And when we break out these values to the non-IVF and IVF conceptions, we do see an gradual increase, and more patients who underwent IVF were more likely to have higher estradiol levels as well as progesterone levels. So what we did is metabolomic profiling in that late first trimester. So after they've been off of hormones, and this is the time when the placenta takes over. Usually the placenta takes over to produce hormones at about 8 weeks gestation, and it is no longer reliant on exogenous hormones or the corpus luteum. So these were 12-week pregnancies again, and we did metabolomic profiling, and we see that fatty acid metabolism pathways are enriched, progestin steroids are enriched, and then when we compared the extremes of the spontaneous to the IVF, we found that also, in addition to the progestin steroids and fatty acid metabolism, phosphatidylиноxidil, phosphatidylethanolamine, and diacylglycerol were also elevated. And these are like the energy building blocks for all metabolism. And we also looked at the metabolites of the progestin pathway and the estradiol pathway. And what we think is happening is when we give supraphysiologic hormones very early on in pregnancy, the placenta gets reprogrammed to continue to stay in this high hormonal state in order to preserve maintenance of the hormones. And so the diacylglycerol and the phosphatidylethanolamines can be contributing to this high energy state, leading to cholesterol production to be shunted towards progesterone and estradiol production. So when we look at those in red, those were higher in the infertility population versus those in green. Metabolites were higher in the spontaneous conceptions. So cholesterol is being shunted more towards the progestins and away from the bile acid pathway in the infertility population. And androstenediol is, and the androstenediol is being shunted towards the estradiol pathways as opposed to androstenediol metabolites. And so we know that hormones do regulate our individual cell types in the chorionic villi. And when we did single cell sequencing of the first trimester chorionic villi, This is a PCA plot or a T-SNE plot where each of these different dots is an individual cell, and it gives us the transcriptomic information of each individual cell and helps us cluster the different cell types. What we found is what was regulating these different cells. And we see that in all cell types, estradiol is an upstream regulator of trophoblasts, stromal cells, macrophages, and dendritic cells and endothelial cells. And progestin also appears to be a factor contributing to trophoblast cells. So we started looking at one factor that we had seen that was differentially methylated, an upstream regulator known as GATA3. GATA3 directs trophectoderm differentiation in the blastocyst very early on. It regulates function for placental vascularization, syncytiotrovoblast formation, and reduced levels of GATA3 in mice show decreased embryo hatching and implantation. And when we looked at GATA3, we found that estradiol actually downregulated GATA3. And when we looked at what it impacts in terms of how these trophoblast cells migrate and invade in order to form the placenta, we see that it inhibits migration and invasion, whereas progesterone did not have an effect on these trophoblast cells, suggesting that sometimes supraphysiologic hormones may not be super beneficial. And largely, a lot of our field has transitioned out of using embryo transfers in IVF cycles because they're in a high hormonal state, and we've transitioned to using more natural cycles of embryo transfers, and this is part of the reason to help improve outcomes, and this data supports all of our decisions to do this. So then what we did is, in order to sort of tie this data together, is we did a multi-omics analysis, which is known as a regularized canonical correlation analysis, because this allows us to correlate data along a large data landscape using small sample sizes. And we looked at traits of phenotypes, genomic traits from our single nucleotide variants, methylation hits, transcriptomics, and metabolomics. And what we found is we looked at different components, and component 3 of this RCCA analysis was associated with the infertility across the landscape, but it was not impacted by sex, maternal age, race, or CVS age. And we found that there was a number of features that were identified, and these features consisted of genomic features, methylomic features, metabolomic features, and transcriptomic features. And one of the common themes was mitochondrial regulation. So we think that there is some factors that contribute to regulation and metabolism of the placenta. We found mitochondrial regulatory genes that were impacted and mitochondrial small RNAs, which are nuclear encoded, and they're regulators of mitochondrial transcription, so the energy behind all of our cells. So based on some of the work we've already done, and as others have done, is that infertility and the treatments associated with the increased adverse outcomes that we mentioned, overall, these risks are small, and the risks are independent of the treatments utilized, and all the outcomes appear to be related to placentation. The genetics of infertility appears to be the major contributor that alters the methylation and gene expression. And the supraphysiologic hormonal states may be contributors. They may alter methylation, reprogram the placenta to maintain a high hormonal state, and impact trophoblast invasion and migration. And multi-omic studies suggest the genetic and epigenetic impacts might be on the mitochondrial genes in the first trimester. So as we started thinking about what should we do next, and we know that it's most likely the genetics, is looking at whether or not infertility etiologies are the contributory factors to change the genetics and epigenetics, as well as what we know of the environment, which now we're able to control, in particular our IVF patients, to overall reduce the short-term and long-term outcomes that might be impacted. And so we started to look at PCOS, endometriosis, and unexplained infertility, and other factors such as male factor infertility also play a role. And more recently, a study came out looking at methylation changes in sperm, and they also see methylation changes that may be consistent with what is also changing in pregnancies as well. So again, these are the factors that may be largely contributory. So one of the diseases that we focus on is endometriosis. And so we did a single cell transcriptomic analysis of endometriosis with a large group, including our MIGS team and Kate Lawrenson, who's now at UT San Antonio, but is still one of our great collaborators, to understand what endometriosis is at the single cell level. And so what we did is we took endometriosis from multiple patients from multiple different sites in the peritoneum, and we also took additional peritoneal tissue at the time of surgery to make and develop an atlas of endometriosis. And the interesting thing we found, so these are, again, these UMAPs or T-SNE plots, which plot out each individual cell based on its gene expression, and then the interesting thing we found is that there's a lot of inflammatory activity. So the T cells and the NK T cells are really highly expressed in endometriosis and in endometrial implants and in endometriomas, suggesting that endometriosis is an inflammatory disease, and there is some other data suggesting that it might be some type of autoimmune dysregulated disease, and we have to focus on those pathways in order to help us better understand. And when we look here, and these are the different cells that we see among the different classes of tissue, we see that endometriomas in the dark purple are highly represented in the population of T and NK T cells, as well as eutopic endometrium and endometriosis. So we see it also in the endometrium as well. When we defined changes across the different types of cells where we did the biopsies, we do see that these are different genes that are expressed based on the tissue type of the individual cells. And we see that the genes that are differentially expressed in endometriomas are different than the genes that are expressed in eutopic endometrium as well as endometriosis. So they all have their own genes that they're expressing, so they're quite unique. So we can't just say somebody has endometriosis. We actually have to take it one step further to better understand what is the phenotype of the endometriosis in order to help us find better treatments to help our patients as well as help them conceive successfully. And when we also look at pathways, so this is pathway enrichment of the genes that are expressed in these different cells, we do see various different immunologic factors, particularly of endometriomas. And neutrophil degranulation is present in all endometrial subtypes, including endometriomas, normal eutopic endometrium, which is that within the uterine cavity, as well as endometriosis. And then the endometrium and endometriosis have other pathways that are being regulated that are more unique from the endometriomas. So in order to study these genes that we found that might be differentially expressed, differentially methylated, and how it relates to the infertility and the diagnosis of why couples have infertility, we started trying to derive trophoblast cells from trophoblast stem cells. And so there's been a couple of studies that have been conducted. Okai and their group has used trophoblast stem cells from about 6 weeks terminations, but we decided to also look at the first trimester placenta because, again, these are cells that we can look at, we can derive, and we could individualize them based on what the diagnosis is, as well as see what happens with these ongoing pregnancies. So what we did is we derived and compared them to the stem cells that are readily publicly available, and we were able to derive them into extravillous trophoblast cells. So they have this outgrowth appearance here, where these are the cells from the chorionic villi, and these are the cells from the Okai line, which is done from an earlier time point in gestation, but without outcomes of the pregnancy. And we also look at markers that are expressed to see if these are actually differentiating into these extravillous trophoblast cells. And HLA-G is one of those markers, and we see that it's highly expressed, suggesting that we're able to derive these trophoblast stem cells into EVTs and potentially use them for studies and manipulate them with any of the changes we see from our patients. We also looked at what other factors were expressed. And when we compared these trophoblast EVTs to the stem cells continue to express genes that are consistent with stem-like genes such as TEAD4, LRP2, and LIN28A, whereas the genes that are expressed and consistent with EVT formation are highly expressed in the differentiated extravillous trophoblast cells, including HLA-G, MMP2, and CCR1. And we did RNA sequencing to look at all the genes that are differentially expressed, and we see quite significant differences between the stem cells and the derived extravillous trophoblast cells from the stem cells that were present. We were also able to derive syncytio trophoblast cells from the trophoblast stem cells. So they have a bit of a different appearance histologically because they are merging, because the syncytio trophoblast cells basically merge to become one multinucleated cell to form a sheet. And we see that this is also consistent when we develop these stem cells and derive them into syncytio trophoblast cells in culture. And similarly to the EVTs, we see that the stem cells continue to express high levels of stem genes. And when we looked at genes that are consistent with syncytio trophoblast cells, such as CYP11A1, CG beta 7, which is HCG, which is what they produce, and SDC1, we see high expression in our syncytio trophoblast cells. And when we did RNA sequencing of various different other genes, we see the difference and the phenotypes and the gene expression changes in the syncytio trophoblast cells are pretty consistent with what we see in the underived syncytio trophoblast cells. So as we're starting to move forward, we're trying to understand the underlying infertility etiologies and then be able to pinpoint them. And now we have this tool or model system of the chorionic villi. So we can identify chorionic villi from individuals who've conceived with the different types of infertility in order to be able to study it further, understand what the underlying infertility diagnosis is contributing to these pregnancies in order to get better answers for our patients and find ways to improve outcomes. And so I would like to thank everybody who's been working in my lab tirelessly for many years, particularly Tanya Gonzalez, who's been my research scientist and has been with me for many years and has trained so many of our fellows who come through the lab. I'm also grateful for everybody who's been part of our prenatal biorepository, which we developed over the last 12 years or so to be able to do these studies. My faculty, Erica Wang and Jessica Chan, and particularly John Williams in the maternal fetal medicine division, who has basically been the person who's done all of those CVSs to help us bank for the future, as well as some of our pediatrics colleagues in UVA, and our collaborations with KUMC and Mike Soares and Kayla Varberg. and UT San Antonio with Kate, and of course funding through the NIH. But mostly I have to thank our patients who participate in our studies, because if it's without them, we would not be able to understand what we need to do to move our field forward. And I know I always say this, and as we were talking about how the patient whose son is getting married soon, the baby who's on the front and in all of those pictures is actually my last baby. And now he's graduating from high school and he's shown here. So he's not my baby anymore, but I always like to put him in to our pictures as, a reminder of what we're here for. So thank you, everybody. And I'm happy to take questions. And I'm also really excited about all the great work that you're all doing here today.
We have time for questions. We have microphones.
Testing. Thank you so much. That was really incredible. I have two questions, one sciencey and one not. So you said earlier on, when looking at some of the clinical outcomes, birth defects, we stratified based on conventional IVF and ICSI. Later on, it looks like a lot of the studies looking at, chorionic villi or methylation really are just kind of combining IVF and ICSI. So my first question was, what are your thoughts on that? And then my second question is, a lot of the presentations today are fellows, junior faculty. You obviously have an incredible career. We also know you're very busy clinically and you have 3 kids. So just curious about your pathway and what advice you would give to young faculty and fellows.
Great, thank you. Those are 2 great questions. So thank you so much. So actually, we did look at the ICSI versus the IVF conceptions with the methylation data, and we really didn't see too much of a difference at all. So I think, again, we have to delve further, because I really do think it's the genetics that plays a role. But fortunately, and as we look at it, these risks are really small. And what I try to even tell our patients is that you might be at increased risk. We're going to monitor you more carefully. We're going to be looking at things to make sure your pregnancy runs as smoothly as possible, and we could intervene when we need to. And like the thing I had mentioned earlier, which was really important, is the transition of putting embryos back into a more natural environment, so we don't put embryos in directly once they've been stimulated, because they're at these high supraphysiologic states. We give them a month's rest, and then they have their embryo transfer. And I think that plays a significant role in overall outcomes. So I think that was something else that we learned from our environmental studies, so I think that's definitely helpful. And now, as we look towards some of the things, even with endometriosis, we're trying to better understand, are there anti-inflammatory things that we can do in order to improve outcomes and the like. And we're trying to get some start data to start delving into all of this. So more to come on the different disease types for us to look at. And so, yeah, thank you for asking that question. That was probably, I don't know if that was one of my talks, because we were at a fellows retreat, and I spoke at that retreat a number of times, and it's really the most fun thing to do, because you meet all the fellows. And I used to speak about, career paths and stuff. And I think the big thing is, again, always to continue to be curious. Like my mind, I'm constantly like, my brain is on like 100% all the time, 110%. And so I jot things down. I'm like, oh my God, I have an idea, and I'm just going to write it down and the like. But I think it's also like, you have to love what you do. And, this is not the career path I ever had intended to do. And I used to give a talk where I'm from New York, and it's like the fortuitous paths, and things happen for a reason. But I'm from New York, and I was moving to Boston to do my fellowship. And then the fellowship director called me and said, well, I'm moving and I don't have a position for you anymore. And I was devastated and cried for a month. And then fortunately, there was one position that was still open at Baylor in Houston. And I did an interview there. I didn't have any interest in leaving the Northeast. And I went down there and I brought my husband, who's from Boston, and we met the people there. And it was Sandy Carson and John Buster and Jolie Simpson and Peter Casson. And they were the most wonderful people I have ever met. And I told my husband, I'm like, we're moving to Texas. And he was like, not really, but he did come along. And it just opened up because it was, my goal was to move back to New York, you know, like Sex and the City, go shopping on Madison Avenue with my girlfriends, and then go and do my job, my day job. And then I was exposed to like the most incredible people who were doing genetic knockout mice, and Franco De Maio and Marty Matsuk and Joanne Richards were there. And I took a class with them. And they were telling me how, you know, how they can manipulate the genes in a mouse and cause a phenotype. I'm like, wow, you could really do that? I'm like, that's so fascinating. And so then my husband, thankfully, he's very supportive. I was like, this is what I want to do. I'm like, I want to do research. So then off I go. And instead of moving back again to New York or the East Coast, I moved to the West Coast, and I ended up going to Stanford, and I met another wonderful person. Well, Linda Jadis was wonderful. She was my division director, and Aaron Shui, who was a very hardcore person and thought I didn't work hard enough sometimes, but I got it done. And it was great because I learned so many things because I didn't even know how to work in a lab or run gels. And then after that, things just kept evolving. And it was really because it's something that I just really love to do. And it wasn't really just work. It was like, oh, let's think about things through. And so with the kids, so then we had one child in each city we lived in. We kind of spread them out because I couldn't afford childcare. So I would moonlight and then we would pay for it. And then ultimately, the thing that I think is so important, and I've told my faculty this too, is that worked out well is you try to live close to work, close to your kids' school, because then you don't have to worry about these long commutes in order to be able to maximize your time with them. And many a times I would go to their sporting events. I would have my laptop. I'd be sitting in the chair mostly for softball and baseball because it's really, you know, it's a slow game. And so I'd be sitting on my laptop. I'd be like, oh yeah, Alex is up. And I would do like work when she was there. And even during the work week, you know, you balance your time. And if they have an event at school, you make sure you go, even though they tell you not to. And they're like, we don't want you there, Mom. You know, don't embarrass us. That's not true. They actually appreciate it. And so it was just kind of trying to find that balance of working through things. And, you know, you just sort of bring it all to home. My mother moved in with us because she was older. It was easier for us to manage Mom at home and later my mother-in-law. So, and my kids got super influenced. I have my daughter's getting her MD PhD at Columbia and got married last weekend. And my middle son is at the NIH right now, trying to get his MCATs, to take his MCATs eventually. So and my youngest son wants to play football. So, you know, but it's finding the balance and really finding pleasure in what you do. And sometimes there are really bad days, and we all have them. And we're just like, we have to put them aside. And I focus on I try to focus on the positive, particularly with my kids. That's why they don't know what healthcare sometimes is really about. I'm like, Discovery Day, Wednesday's my research day, my lab meeting day. So they knew to ask me questions on my research day because I was always in a good mood. So they'd be like, Mom, we need this. And they would always get it on Wednesday. But so just, you know, try, you know, your best, and your kids will appreciate, like, you know, everybody worries about, I'm not there for my child on certain days, and, you know, Mommy's traveling, but there's always the little things that they will appreciate. and they will so appreciate you as a role model as they get older and say, you know what, Mom, you could do it, or Dad, you could do it. And that's what really makes a difference. And, but yeah, you just keep on. Don't let the failures bother you. And, you're not going to get your first grant funded. And it takes, one of my former mentors told me, it takes 10 grants to get one funded, because that's what the NIH is at, the 10 percentile. And you just refurbish them and, make some adjustments, and then eventually something will stick, and then off you go on to your career.
Good morning and welcome back. I am going to be the first one to start introducing the fellow research, and it is my great honor to introduce Dr. Infusino. Dr. Infusino at the medical school at the University of Quinnipiac and the residency at the University of Maryland, where he, much like many of us, discovered his great love for ultrasound and fetal medicine. And that is obviously something that both him and I share deeply, and you would see through his research. He's been a absolutely great advocate and great person to have around for the last 3 years in terms of advancing what we know from ultrasound, and fetal growth restriction is particularly a topic that concerns most of us in MFM. And so hopefully he can shed some light into this through his presentation today, although this is kind of the tip of the iceberg, but you will, I'm sure, enjoy it. So please welcome Dr. Infusino.
Thank you very much. Good morning, I'm Scott Infusino, and my research presentation is fetal cerebral Doppler in late onset growth restriction and preeclampsia. Fetal growth restriction is one of the leading causes of adverse perinatal outcome. The foundation of pregnancy management consists of fetal Doppler evaluation. Growth restriction can be categorized into early and late, with early diagnosed before 32 weeks and late onset growth restriction diagnosed at 32 weeks or later. Early FGR has this observed sequence of Doppler changes and deterioration that guides management. But what is the Doppler progression in late onset FGR? There really isn't one. With late onset growth restriction, you often will not see an abnormal umbilical artery Doppler. Your placental disease is different. With growth restriction, as you have worsening placental function and developing hypoxemia, you have redistribution of your blood to vital organs. Your cardiac output changes, your middle cerebral artery dilates, and as a result of these changes, your pulsatility index decreases. The cerebral placental ratio is the ratio of middle cerebral artery pulsatility index and the umbilical artery pulsatility index, and can detect subtle changes from both of these parameters. This also decreases with worsening FGR. An important thing to consider with growth restriction is that preeclampsia is a common comorbidity and impacts your clinical course. The figure on the right shows that time to delivery from any Doppler abnormality in early onset FGR is shorter when complicated by preeclampsia, represented in the gray bars. But data is limited when it comes to late onset growth restriction, as well as cerebral artery Doppler. Therefore, the objective of this study was to determine if the presence of preeclampsia impacts the rate of abnormal middle cerebral artery pulsatility index and cerebral placental ratio, as well as clinical outcomes in pregnancies complicated by late onset growth restriction. This was a retrospective cohort study at a single academic center. Data was collected from PeriData, Viewpoint, and the electronic medical record. Non-anomalous singleton pregnancies with late onset FGR that had serial umbilical and middle cerebral artery Doppler evaluation were included. MCA pulsatility index and cerebral placental ratio were considered abnormal if less than the 5th percentile for gestational age. It's also important to note that while MCA Doppler evaluation was performed on these patients, it was not used as criteria for delivery. All preeclamptic cases diagnosed antenatally, both with and without severe features, were included in our preeclamptic cohort. Standard statistical techniques were used to analyze our data. Our primary outcome was the rate of abnormal MCA pulsatility index and cerebral placental ratio in pregnancies complicated by FGR and FGR with preeclampsia. Secondary outcomes included delivery characteristics and outcomes and neonatal outcomes. We had a total of 423 patients with late onset FGR and 53 patients with late onset FGR and preeclampsia. Overall, our two populations were similar. Our preeclamptic cohort was more likely to deliver 2 weeks earlier at 36 weeks gestation. The late onset FGR cohort was more likely to make it to their scheduled delivery time, while the preeclamptic group was often delivered early because of preeclampsia, understandably. Preeclamptic patients were significantly more likely to have a cesarean delivery and to have a lower birth weight. There were no stillbirths in our population. With regards to our primary outcome, our preeclamptic patients were significantly more likely to have an abnormal cerebral placental ratio, middle cerebral artery pulsatility index, or abnormal values for both. When looking at delivery timing, our preeclamptic cohort delivered at an earlier gestational age, regardless of whether or not there were Doppler abnormalities, showing that preeclampsia is the main driver for early delivery. And when you specifically look at patients who have cesarean deliveries for non-reassuring fetal heart tracing, you have significantly more patients in the preeclamptic group with this indication for delivery. The proportion of abnormal Doppler values compared to our total patient population is dramatically different, although this is an overall small subgroup. In the overall FGR cohort, only 9% had an abnormal CPR, while 40% in this subgroup had an abnormal CPR, and 30% of our total preeclamptic cohort had an abnormal CPR, while 80% in this subgroup was abnormal. This is likely a driving factor for cesarean deliveries for non-reassuring fetal heart tracing, which is consistent with prior literature, just worse in our preeclamptic group. When you look at the patients whose delivery indication was non-reassuring fetal status, you find some interesting things. 5 of these patients had some abnormal cerebral artery Doppler, with most having a very abnormal Z-score for their CPR MCA Doppler at -3 or less. This also occurred in the setting of normal umbilical artery Doppler in some cases. There were 4 patients who had enough Doppler evaluations to look at a trend, and they all had a concerning pattern where there was this precipitous decline in either the MCA or the CPR. Patient 1 also had a precipitative drop in the cerebral placental ratio, however, it never became abnormal before delivery. When examining neonatal outcomes, including NICU admission, assisted ventilation, IV treatment of hypoglycemia, prolonged infant length of stay, and if infant not being discharged with the patient, there appears to be an increasing trend in worse outcomes with FGR, then FGR with abnormal Dopplers, then preeclampsia with abnormal Dopplers. However, when you adjust for gestational age, there is no significant difference, and all the adjusted odds ratios cross 1, showing that gestational age at delivery is the most important thing with respect to neonatal morbidity. In conclusion, patients with late onset growth restriction and preeclampsia were more likely to have abnormal MCA and CPR Doppler, earlier gestational age at delivery, and cesarean delivery with an indication of non-reassuring fetal heart tracing. A particularly abnormal Z-score or sudden drop in MCA or CPR values may be an ominous sign and may be more common in preeclamptic patients. Gestational age is the most important determinant of neonatal outcome. And when you diagnose growth restriction, you should also be thinking about preeclampsia, especially in the setting of abnormal Dopplers. There are a few studies examining fetal cerebral Doppler with preeclampsia. This study was performed at a single academic center, and while there was more likely to be similar management styles among providers, data was based on a limited population and was retrospective. Future studies would ideally consist of prospective multi-center evaluation of fetal cerebral Doppler and pregnancy outcomes. They would ideally evaluate delivery timing with respect to neonatal outcomes with abnormal MCA pulsatility index or cerebral placental ratio. Studies should also evaluate outcomes when examining the degree and trend of MCA and CPR abnormality. There really was a small patient population with these particularly severe Doppler findings, and multi-center collaboration would be key to truly understanding best management and surveillance. Here are my acknowledgements. I would like to give a special thanks to my mentor, Dr. Igor, as well as Natalia Uchkowski and Amy Godecker. This project would not be possible without their help. Thanks.
hold it, but so question, because it was very interesting that you mentioned that these late fetal growth restriction is potentially associated with preeclampsia. So have you, when you do see this, are you now screening patients to rule out preeclampsia because they, of course, would be the ones to be delivered earlier?
Thank you for that question. So we don't have a change in protocol for our patients in terms of really screening for preeclampsia, but with our antenatal testing, we always check blood pressure and check how patients are doing. So from that perspective, we are monitoring for hypertensive disorders of pregnancy, but there's not a specific change in our screening. All right. Thanks.
I'm going to be introducing Dr. Patel. Dr. Ushma Patel is a third-year fellow in the Division of Urogynecology, Reconstructive Pelvic Surgery at the University of Wisconsin. She graduated summa cum laude from Marquette University and then received her medical doctorate from the Stritch School of Medicine at Loyola University in Chicago. She completed residency in obstetrics and gynecology at the University of Wisconsin, where she stayed on to be our second-year fellow, and we're very proud of her. Upon graduating, she will join the faculty at the Medical College of Wisconsin in Milwaukee. In addition to being an astute clinician and a very gifted surgeon, Dr. Patel is deeply committed to advancing the field of urogynecology. Her manuscript entitled Updated Prevalence of Urinary Incontinence in Women, a 2015 to 2018 National Population-Based Survey data, was awarded the top-cited article by Urogynecology. She is active in the American Urogynecologic Society and serves on the Pelvic Floor Disorder Week Planning Committee. Today, she will be presenting her thesis project, Duration of Use of a Digital Therapeutic for Fecal Incontinence, a randomized non-inferiority trial. Dr. Patel.
Thank you so much, Dr. Pennycuff. Thank you to the department for the opportunity to present our work today. These are our disclosures. Fecal incontinence is an unintentional loss of solid or liquid stool and is underdiagnosed but common, with prevalence estimates ranging from 7 to 15%. Currently, conservative management with behavioral modification, medications, and pelvic floor physical therapy with biofeedback are first-line therapies for fecal incontinence, but require significant patient motivation. Considering disparities in access to pelvic floor physical therapy and the social stigma associated with fecal incontinence, there is a need to investigate at-home treatment modalities for fecal incontinence. Digital therapeutics represent an emerging treatment modality in which digital systems like smartphone applications are used as prescribed interventions to treat medical conditions. Digital therapeutics are well described for urinary incontinence, but fewer data exist about their use for fecal incontinence. While there are data supporting pelvic floor exercises with biofeedback for fecal incontinence, many of these studies report on clinic-based intraanal devices with varying treatment protocols. The optimal timeframe for treatment still needs to be determined. There is a pelvic health system that's FDA cleared for the treatment of urinary incontinence, pelvic floor weakness, and fecal incontinence in women. The device is pictured here and incorporates an intravaginal motion-based wand that pairs with an app on the user's smartphone to facilitate at-home biofeedback therapy. The intravaginal motion-based wand detects pelvic floor motion, which is visually depicted in the user's app as degrees of motion from baseline, presenting real-time feedback on correct and incorrect pelvic floor muscle exercises. Participants use the device for 2.5 minutes twice daily, following 15-second contractions and 15-second rest periods. Remote health coaches are available to assist with training. The primary objective of this study was to evaluate whether 8 weeks of use of this pelvic health system was non-inferior to 16 weeks of use to treat fecal incontinence in women. Secondary objectives were to examine the impact of duration of use of the pelvic health system on the patient-reported outcome measures listed here. And further secondary objectives were to evaluate usability of the smartphone app, to characterize parameters of device use, and report on safety data. The primary outcome was change in fecal incontinence severity quantified by the VASI score from baseline to 16 weeks. The VASI score is listed here. It ranges from 0 to 24 points, and a score of 24 signifies complete incontinence, while a score of 0 signifies perfect continence. It measures the severity of fecal incontinence symptoms in the last 4 weeks. Sample size calculation is shown here. The minimal clinically important difference, or MCID, for the VASI score is a 3 to 5 point improvement, and we hypothesized that both groups would have at least a 3-point improvement in the VASI score. Allowing for attrition of 20%, recruitment of 38 participants was planned, with 19 in each arm. Community dwelling women 18 years or older with at least monthly fecal incontinence for 3 months who had a smartphone were able to vaginally insert the pelvic health system and perform standing exercises were eligible to participate in the study. Exclusion criteria listed here, and for the sake of time, I won't read through them. We designed a single center, single blind, randomized non-inferiority trial evaluating duration of efficacy of the home-based digital therapeutic pelvic health system for the treatment of FI. IRB approval was obtained and the study was registered at clinicaltrials.gov. All participants completed a baseline exam consisting of POPQ and Brink score, and the questionnaires listed here. At 16 weeks, participants completed in-person follow-up and completed the surveys listed here. And at 24 weeks, participants virtually completed repeat surveys and evaluation for any self-continuation of pelvic floor exercises. Participants were awarded up to $150 for participation in the study. This slide explains our statistical analysis, and also for the sake of time, I'll move on. Participants were recruited through recruitment flyers, campus-wide email, and recruitment letters to urogynecology clinic patients. In total, 583 women were screened, of which 38 were enrolled and randomized. Before enrollment, all eligible participants provided written consent. Study coordinators randomized participants using block randomization and a 1-to-1 ratio to either 8 weeks or 16 weeks. The device was shut off remotely at the end of the allocated treatment arm to prevent participants from continued use with biofeedback device. 19 participants were allocated to each arm, and 18 participants in each arm completed 16 and 24-week data collection. Study investigators were blind to group assignments. All subjects who logged at least 1 training session and completed the follow-up surveys were included in our intention to treat analysis. These are the baseline demographics. I'll summarize that the majority of participants identified as non-Hispanic white with a mean age of 62 years and BMI of 29. Participants' baseline FI symptom severity was high as measured by the VASI score, and stool consistency was similar between groups. And we didn't include these data in our presentation, but there was a significant difference from baseline between those excluded from analysis and those included in analysis. Both groups improved significantly by 16 weeks as measured by the VASI score. And of note, both groups also met the MCID for the VASI score and had clinically significant improvements at 16 weeks. Improvements in the other survey components, notably the pelvic floor distress inventory 20, were statistically and clinically significant. And there was also statistically significant improvements in the fecal incontinence quality of life survey and pelvic floor muscle strength as measured by the Brink score. Changes in the fecal incontinence quality of life survey were not clinically significant. Our primary outcome assessing non-inferiority outcomes between groups is presented here. Treatment duration of 8 weeks was not inferior to 16 weeks, and as noted, changes in the VASI score reached MCID in both groups. There were no differences between treatment arms and secondary patient-reported outcome measures. There were no significant differences in stool consistency over time in either group, and no differences between groups. I'll briefly mention device use parameters here. The average max hold angle is equivalent to the degree of pelvic floor muscle lift from rest, and the average max hold angle time is the length of time the pelvic floor lift was held, with a max of 15 seconds. Both the average max hold angle and hold angle time improved significantly in both treatment arms. There were no differences between treatment arms for device adherence, coach use, or device use parameters. Mean treatment adherence was high at 75%, noting that there was greater adherence in the 8-week treatment arm compared to the 16-week treatment arm at 84% compared to 66% respectively. However, this difference was not statistically significant. Overall, participants in both groups rated the smartphone app as usable, but with slightly higher ease of use reported in the 16-week group. The estimated percent improvement was high at 57.9%, and notably 75% of our total group reported greater than or equal to 50% improvement in symptoms. When evaluating remote health coach use as interactions per week, treatment adherence, and improvement by age, older participants utilized coaches and adhered to device use more than our younger participants. However, estimated percent improvement remains stable across age groups. And I'll briefly mention our 24-week data here. Results were sustained at 24 weeks despite stopping device use, noting that treatment duration of 8 weeks remained non-inferior to 16 weeks in the VASI score. And at 24 weeks, estimated percent improvement remained high across age groups at a mean of 62.5. There were no serious device-related adverse events reported. Strengths of the study include the prospective randomized single-blind study design, use of patient-reported outcome measures, ability to shut off the device remotely at the end of the allotted treatment arm, the ability to utilize and analyze a smartphone app and remote health coaches, and a low attrition rate over the 24 weeks. The study had a few limitations inability to mask participants, failure to recruit an ethnically and racially diverse sample, and inability to prevent participants from engaging in self-guided pelvic floor muscle exercises after the end of their allocated treatment arm. And I'll conclude that digital therapeutics offer novel treatment for fecal incontinence. Our study found that treatment duration of 8 weeks is not inferior to 16 weeks when using an at-home pelvic health system with biofeedback and remote health coaching. Both treatment durations resulted in statistically and clinically significant improvements from baseline and validated measures of fecal incontinence with results sustained at 24 weeks. Older participants were more likely to utilize coaches and adhered to device use more than younger participants, and overall adherence in the sample was high at 75%. The smartphone application was considered easy to use, and finally, estimated percent improvement was stable across age groups and high at 60%, and these results were sustained at 24 weeks. I would like to acknowledge my co-authors, our statisticians, and the UW Department of Human Subjects Corps, specifically our research coordinators. These are my references, and I can take any questions.
Thanks. Great job, Ushma. And we all know it's no small feat to take on a prospective trial, particularly as a trainee. So congratulations on that. You mentioned the fact that you obviously can't control for, them doing exercises beyond the, 8 weeks or the 16 weeks. But did you have any data related to that? I mean, are we finding out that you really just need to teach them? It doesn't matter how long it matters. It probably matters. 8 weeks does it. But do you think that that's what, do you have any information on whether that is the reason that they weren't different?
Yeah, thank you for the question. So we do have data. We asked them at 24 weeks whether they continued their pelvic floor muscle exercises. The same number of participants in each arm continued the exercises at an average about a few times a week. I didn't present that data here today just for time. And when we analyzed those that continued pelvic floor muscle exercises compared to those that didn't, there was no difference between groups. And this is actually corroborated in other studies using this device to treat urinary incontinence. There are long-term studies at 2 years that looked at participants who continued using the device or didn't, and there was no differences between those groups.
Dr. Patel, there are 2 validated questionnaires for fecal incontinence, the Wexner and the VASI-St. Mark's score. Why did you choose to use the VASI, which is more of an international score, compared to the Wexner, which would be more familiar to an American reader?
Thank you for that question. The VASI score and Wexner score, like you mentioned, are actually very similar. The VASI score has a couple more points of interest than the Wexner score, specifically looking at medication use and fecal urgency. And so some expert opinion thinks that there's a little bit more face validity in terms of being able to assess the patient experience a little bit better. However, the reality is they're both validated, they're both easy to administer, they're both easy to score. And so I think it just comes down to preference. And for our research, we wanted the most data possible. And then the other studies that we modeled our study off of in terms of duration and device use also use the VASI score. Thank you.
Happy to present Dr. Matthew Wagger, who's about to celebrate his 7th anniversary here with us at UW. Congratulations.
Thank you.
Matt has, yeah, go ahead. Matt has been exceedingly productive in his research time during as a fellow. Specifically, he has 6 publications during fellowship, 4 of which are first author in Gynecologic Oncology and Green Journal, amongst others. He has had 5 oral presentations, multiple at Society of Gynecologic Oncology annual meeting on women's cancers. And he also has had 6 poster presentations throughout his fellowship. That does not include other invited oral presentations he's received as well. So he's been very productive, and we're very happy for all he's accomplished, which is allowing him to move on to a faculty position at the University of Virginia starting later this year. So we're excited to hear from Matt today about this project. Thanks, Matt.
All right, thank you. So my name is Matt. I'm here to talk about a project we worked on during my fellowship called Progression-Free Survival as a Surrogate Endpoint of Overall Survival in Randomized Controlled Trials of Ovarian Cancer Maintenance Therapies. So a little background. In the last 10 years, maintenance therapies have changed the landscape of ovarian cancer treatment. Maintenance therapies are administered following primary treatment of a cancer with the goal of preventing or delaying a cancer recurrence. So borrowed from successes in other cancers, trials evaluating interventions such as PARP inhibitors and bevacizumab have quickly paved the way for a new class of medications for patients with advanced epithelial ovarian cancer. So following the publication of several landmark phase 3 trials, PARP inhibitors were approved by the FDA for both the treatment of recurrent ovarian cancer and as a maintenance therapy, which is what we'll be focusing on today, following response to platinum-based chemotherapy. Similarly, bevacizumab has gained approval. However, towards the end of 2022, right as I was beginning my fellowship, indications, particularly for PARP inhibitors, started to change very rapidly. So poly-ADP ribose polymerase inhibitors, or PARP for short, are a class of medications which impair single-stranded DNA repair. In cells where both single-stranded and double-stranded DNA repair is not possible, cell death occurs through a mechanism called synthetic lethality. In ovarian cancer, PARP inhibitors exploit defects in BRCA-mediated DNA double-stranded break repair and homologous recombination deficiency. So that's around like 20-ish% of our patients that are presenting with a new ovarian cancer diagnosis might have a mutation in BRCA or be found to be HRD deficient. Bevacizumab is a monoclonal antibody to VEGF, a protein that's involved in angiogenesis and cell proliferation. An interruption of this pathway prevents growth of new blood vessels and cellular migration, leading to senescence and death of new cancer cells. So that's how both of these work and sort of the biologic background for why we started to look into them. So with the introduction of these medications, both the treatment and the prevention of ovarian cancer recurrence through maintenance use of these interventions has changed very rapidly, as I mentioned. However, since these indications have undergone a major change, we wanted to look at why we think that this is maybe happening and what was going on with the trials that led to these approvals in the first place. So following updated overall survival results from the NOVA trial demonstrating a hazard ratio that was greater than 1 in favor of placebo for patients with BRCA wild-type recurrent ovarian cancer, the FDA called for restrictions and withdrawals of various PARP inhibitors without an obvious survival benefit. So at the same time, mature overall survival data began to emerge from other phase 3 trials suggesting no benefit to certain molecular subgroups, like homologous recombination proficient or BRCA wild-type tumors. In the summer and fall of 2022, 5 different indications for PARP inhibitors were withdrawn by the FDA in both the treatment and maintenance setting, with olaparib withdrawal for recurrent BRCA wild-type tumors occurring a year after that. So in response to these changes, ASCO issued a rapid update in September of 2022, summarizing the rationale for the changes in FDA approvals, anticipated further changes, and restrictions, as well as current best practice for the prescribing of PARP inhibitors. And while similar restrictions haven't been seen for bevacizumab in ovarian cancer, historical limitations for this medication have occurred in other cancers, notably in breast cancer at the beginning of 2012 when bevacizumab was withdrawn given further data, failing to demonstrate lack of a survival benefit. At the time of withdrawal, bevacizumab had been FDA approved for the treatment of advanced or metastatic breast cancer for 4 years. So shown here is a constructed timeline of approvals and withdrawals of PARP inhibitors over the last 10 years. You'll notice that there currently is no indication for monotherapy with PARP inhibition in ovarian cancer, meaning that we're not using this to treat cancer. We're using it to prevent it from coming back or prevent it from progressing. Currently, only niraparib has an agnostic approval in the frontline setting for maintenance therapy after platinum-based chemo, so meaning that anyone that has an ovarian cancer diagnosis after they receive platinum-based therapy, you could consider that medication, which I think many people are not, unless they have a specific biologic rationale for it. So currently, PARP inhibitors are largely approved and increasingly administered following frontline treatment for patients with germline or somatic BRCA mutations, or those who demonstrate homologous recombination deficient tumors. Recurrent maintenance indications are exclusively limited to the BRCA, germline, and somatic population, as I've shown here. So why did this happen? Progression-free survival is a generally accepted traditional endpoint for overall survival in many prospective clinical cancer trials. This is typically used as a surrogate to speed translation of interventions to practice, as many trials powered to overall survival as a primary endpoint need to be bigger and they take more time for mature data to become available. So progression-free survival is not perfect, and it's vulnerable to biases. Depending on how a trial defines progression, either by a central review or by investigator review, this can introduce potential bias into how accurate these assessments are. Additionally, assessment time bias, referring to how frequently assessments are being made and when a progression event is captured or detected, may differ trial to trial and not necessarily reflect real-world practice or experiences. In 2010, the Gynecologic Cancer Intergroup convened and issued a consensus on clinical endpoints in gynecologic cancer clinical trials, noting that for maintenance therapies in ovarian cancer, the same criteria adopted for phase 3 therapeutic trials should apply, despite a lack of correlative evidence. So given the evolving landscape of maintenance therapies for ovarian cancer and the complexities of post-progression management of patients receiving maintenance therapies, we wanted to evaluate progression-free survival as a surrogate endpoint for overall survival with a focus on PARP inhibitors and bevacizumab. So we conducted a comprehensive search of Medline, clinicaltrials.gov for all registered phase 3 trials evaluating PARP inhibitors, bevacizumab, or both as maintenance therapies in epithelial ovarian cancer. And that was conducted at the beginning of July in 2023. Enrollment numbers, follow-up time, progression-free survival, and overall survival data were abstracted, as were hazard ratios. Correlation analysis was performed using weighted linear logistic regression, and Pearson's correlation coefficients were calculated. Criteria for progression-free survival as a valid surrogate required an R-squared value of greater than 0.8, which is accepted in literature elsewhere for validative purposes and other clinical endpoint studies like this one. We registered this review prospectively with Prospero, and the data is presented in a meta-analytic format here. So following our initial screening, we identified 60 registered trials meeting our initial search criteria, 11 of which were ultimately included. Most trials excluded did not incorporate the interventions of interest into a maintenance setting, and 4 trials were phase 2 trials. And for 2 of those trials, hazard ratio data and placebo control were not utilized. So ultimately, 6 trials evaluating PARP inhibitors, 4 trials evaluating bevacizumab, and 1 involving both were included. Across the 11 trials, a pooled sample size of 6,243 patients were included. The median follow-up time was 60.3 months, and 3 of the included trials relied on central review to define progression-free survival, while the remainder relied on investigator assessment. And here you can see the individual trials and arms evaluated across the different maintenance therapies that were included. So of the included trials, all but one, GOG 218, demonstrated a statistically significant improvement in progression-free survival at initial data analysis. Comparatively, upon maturation of overall survival data, only the SOLO-1 trial demonstrated a difference in favor of PARP inhibitor in both progression-free survival and overall survival compared to all other included trials which did not. It should be noted that even though this skews, less than 1 on this plot here, that trial did not actually have a statistically significant benefit in overall survival because they had so many interim analyses that were conducted. And so while there is a clinical benefit, there wasn't a statistical one, which I know is, you're not supposed to say that, but it's true. So when plotted against one another, you can see the line we draw through our data is relatively flat. Each of these circles represents an individual trial, and the size corresponds to the sample size of each. Through linear regression, we obtained an R-squared value of 0.35, suggesting the relationship between progression-free survival and overall survival hazard ratios for the included trials is minimally linear. Furthermore, when we dichotomize the trials into PARP inhibitor or bevacizumab maintenance, you can more clearly see the more profound effect on progression-free survival observed from PARP inhibitors, which is not necessarily reflected in overall survival, meaning that these darker blue circles, which are the PARP inhibitor trials, are further away from this line The bevacizumab trials are closer to the line, meaning that as that data is fit, the bevacizumab trials are more predictive than the PARP inhibitor trials, which appear to be very random in driving this result that we're seeing here. So lastly, our correlation coefficient for our primary analysis computes at 0.59, again suggesting a low correlation. This suggests that while linear regression fits our line to this data, the likelihood that in a trial setting, progression-free survival hazard ratio would ultimately reflect an overall survival hazard ratio in favor of one of the maintenance therapies is low. And when we split this data by maintenance therapy, we actually see a moderate correlation between bevacizumab and our linear regression equation at 0.81, while PARP inhibitors remain low at 0.26. And it's worth noting that of the included trials that evaluated bevacizumab, progression-free survival was defined by time to progression or death from the beginning of treatment, which included systemic chemotherapy with platinum, which may affect these results. So in conclusion, progression-free survival as a marker of overall survival does not appear to be a reliable surrogate in maintenance therapy ovarian cancer trials. While moderate correlation is seen in the subset of trials incorporating bevacizumab, the overall linear regression is weak and may be affected by the inclusion of systemic platinum-based treatments into these metrics. We would call for the inclusion and evaluation of additional endpoints to support the continued use of progression-free survival as an endpoint in this setting, and further approvals for maintenance therapies should take caution when considering progression-free survival alone. So an ongoing component of this work is to compare how these interventions correlate across the primary and recurrent maintenance setting, for which data analysis is ongoing, as I mentioned. Notably, maintenance therapies, as mentioned, are not specific to ovarian cancer, and maintenance immunotherapy and hormonal therapy are utilized in other cancers, such as endometrial and breast. An evaluation of clinical endpoints in this setting is similarly warranted. Lastly, patient-reported outcomes, particularly in the maintenance and recurrent cancer settings, are warranted to continue to understand perspective on how these interventions affect quality of life and survivorship. Oh, my time is up, sorry. In the immediate future, Dr. Barucha is going to be presenting this work at ASCO at the beginning of next month, and here she is with her poster. You can catch her in the Gyn session Sunday, June 1st at 9 a.m. in the McCormick Place Convention Center. Agreed. This is our team that worked on this project. Thank you.
Thank you so much. I think that's really important work. And clearly, as we try to understand how to use these types of drugs, both in terms of how the clinical trials are designed and also the basic molecular chemistry of how these things work, are both important. So speaking of, I want to take you into a different direction. So, PD-1 inhibitors and a lot of immune therapies have kind of failed miserably in ovarian cancer. Do you think drugs like this that may actually increase the mutational burden and foster creation of neoantigens might be a helpful adjuvant?
Maybe. I mean, I know that we have tried to evaluate that with PARP inhibitors and immunotherapy in the clinical setting, and that has had varying effects that seem to mostly be driven by the PARP inhibitor, less so by the immunotherapy. But yeah, I mean, I think that there's a lot of people that are looking into that right now, and I think it's a valid attempt. I think it makes me think about the way that we evaluate immunogenicity and how these tumors are responding to some of the immune therapy. A lot of our tumors we evaluate like mismatch repair status, tumor mutational burden, as you mentioned, microsatellite instability, that appears to differ drastically across different cancer sites. And so whether or not we have really honed in on what is the best way to evaluate that in the cancers we are using it in, like cervix cancer, endometrial cancer, are we just not hitting the mark with how we're finding that in ovarian? It's hard to say. I don't know if I answered your question, but okay. Thanks.
Good morning. I'm Laura Jacques, and I have the honor of introducing Dr. Abigail Cutler, who is a complex family planning fellowship trained obstetrician gynecologist in our academic specialist group. Her research focuses on access, education, and experience around abortion care. And most recently, her work is focused on the intended and unintended consequences of the Dobbs decision, what we call the year without abortion in Wisconsin. In the past year alone, she has had publications in the New England Journal of Medicine with a commentary about the effects on training. She has had a study published in JAMA Open Network about which she's going to share some of her findings today with you all about the consequences on the ability to provide routine obstetric care in the state of Wisconsin after Dobbs, as well as a recent publication in the Green Journal Open on the consequences on our trainees of this year without abortion. So her work is very important, not always easy to do, and we're very grateful that she's doing it here at the University of Wisconsin. Please welcome Dr. Cutler.
Thanks for that nice introduction and thanks for having me. I'm presenting on our recent study. This talk is titled "The Law is Uninterpretable: Experiences of OBGYNs Providing Pregnancy Care in a Post-Dobbs Wisconsin." So following the Dobbs decision of June of 2022, an 1849 Wisconsin state law widely interpreted to be an abortion ban posed criminal penalties to any physician who provided an abortion for any reason except to, quote, save the life of the mother. Freestanding abortion clinics, which had long provided most abortions in Wisconsin, immediately ceased providing abortion services. Hospitals and outpatient clinics across the state followed suit, leaving physicians without clarity about when it was legal to provide standard care for patients facing complications of pregnancy. Meanwhile, pregnant Wisconsinites were forced to navigate unfamiliar and complex systems to obtain abortion services, often across state lines. I don't have to remind this audience that at a time when maternal mortality is unacceptably high, maternity deserts are growing in number, and rates of moral distress among physicians are increasing, it is critical to understand the impact of abortion restrictions on broader reproductive health care, including the ability to receive needed care and the ability to provide evidence-based care. In this study, we sought to document how the post-Dobbs legal landscape shaped the abilities of Wisconsin OBGYNs to provide care to patients facing pregnancy-related risks and complications between June of 2022 and December of 2023. We also explored the role of healthcare systems in mediating these outcomes, as healthcare institutions remain under-examined influences on the relationship between abortion restrictions and pregnancy care provision. We recruited Wisconsin OBGYNs using a sampling framework intended to achieve diversity of participant characteristics and demographics. OBGYNs were eligible to participate if their scope of practice include caring for patients facing pregnancy complications in the hospital or outpatient setting, and if they had practiced in Wisconsin at least 1 year and 1 year before and 1 year following Dobbs. Trainees were ineligible. Using a semi-structured interview guide, we explored a wide range of topics, including post-Dobbs changes in management of common pregnancy complications, institutional practices, policies, and support, and perceived impact of the 1849 law on participants' professional and personal lives. We used a thematic qualitative approach to analyze interview data. Our final sample included 21 OBGYNs from diverse practice settings. Participant mean age was 43. 3/4 of our sample identified as female. A little less than a quarter identified as non-white. 7 participants had completed a subspecialty fellowship in either maternal fetal medicine or complex family planning. Our findings have so far fallen into 3 broad categories. 1, the impact on clinical care. 2, the response of health institutions. And 3, the impact on the systems that Wisconsin physicians and patients had long relied on to facilitate access to abortion. Since time is short today, I'll be focusing on the study's primary findings, the impact of Dobbs on clinical care. With respect to how the 1849 law shaped clinical care, our qualitative analysis revealed 2 interconnected themes. 1, how the absence of legal clarity contributed to inconsistent and unclear institutional guidance, as well as feelings of vulnerability and internal conflict among physicians. And 2, how all of this resulted in severely compromised patient care. Regarding the first theme, participants described how the imprecise wording of the 1849 law really failed to define when intervening to save the life of the mother was legally permissible. Physicians noted that this life of the mother exception was, quote, not really interpretable, not a medical term, and difficult to define. Not knowing how to apply the law's language into clinical practice, participants turned to their institutions for guidance. Several participants found that the desired guidance they received was sorely lacking. One said, "We don't always know how to interpret legal language. We didn't really get guidance about how to execute ourselves, either administratively or clinically, in the new landscape." Even when some doctors did get guidance from their institution, not all trusted it, which led to variations in care even within institutions, exacerbating confusion over what care was legal to provide. While we did make these decisions about when to intervene as an institution and as a department, not everybody in the department felt comfortable proceeding with offering care because they were worried about the legal risk for themselves. Several participants perceived their institution's guidance to prioritize the safety of the health system over everything else. I felt disappointed that some of the legal counsel that I was receiving may have been grounded more in concern for protecting the health system rather than protecting the patient's best interests or even mine as a physician. Even proactive guidance from hospitals did not necessarily assuage feelings of legal vulnerability among participants. Many expressed concern that their medical malpractice insurance wouldn't cover charges under the 1849 law and had little confidence that their hospital would have their backs in the event that they were charged. I've done everything I can to make sure that I'm abiding by the law, but if I were charged, my employer would want nothing to do with me. They would wash their hands of me as fast as possible and say they had nothing to do with the abortion. You're very much on your own to defend yourself. For many participants, this legal vulnerability created deep internal conflict between upholding their obligations to patients and jeopardizing their personal safety, well-being, and freedom. I had to look at myself in the mirror and say, well, providing an abortion is fundamentally the right thing for this patient, and I can't envision how anyone would say otherwise. So I'm going to do it, and the consequences will be what they are. But I think about my whole family, my whole career. I think of everything that would be poof, gone. Another described how several participants indicated their identity as a parent weighed heavily. As much as I'm here for my patients and want to do everything I can to give them the care they need, at the end of the day, I'm still a human, I'm a mom, I have this life that I've worked really hard for and I want to provide for my children. I can't afford to go to prison to do this. Another described how their racial identity shaped their feelings of vulnerability. In Wisconsin and across America, certain groups like African Americans receive harsher criminal sentences. I was concerned that there would be disparities in incarceration where some would go free and others would spend the full time in jail. Ultimately, the threat of criminalization and the absence of legal clarity led to substandard, delayed, and fragmented care for patients facing any number of pregnancy complications. Care was especially compromised for patients experiencing pre-viable PPROM. One participant described how they had been prohibited from offering delivery until their patient showed signs of infection. The patient ended up getting infected. Only then were we allowed to proceed with the induction. She did go on to deliver vaginally a stillborn infant. However, she became so sick that she was admitted to the ICU with concerns for sepsis. And so it should have been a less than 48-hour stay turned into a 5-day admission, including ICU care. Due to differing interpretations of the law's language across institutions, even within the same state, larger Wisconsin hospitals increasingly found themselves on the receiving end of patient transfers from other institutions whose physicians did not feel comfortable offering or were not permitted to offer certain interventions. We got a lot of transfers, people that got really sick waiting for care because they couldn't intervene earlier or thought that they couldn't intervene earlier. And delays in care were not limited to second trimester complications like PPROM. One participant described a patient whose multiple comorbidities increased the risks of pregnancy to her underlying health. However, she said, none of those comorbidities or medical problems included PPROM, preeclampsia, hemorrhage. She was deemed by a committee of people to not meet the threshold by which we could confidently intervene and still feel like we were following the law. Yet another participant described the impact on patients with suspected first trimester pregnancy failure. We have to have a lot of them come back for multiple images and labs to, quote, confirm this before we can intervene, which results in a lot more emotional and physical distress for these patients, potentially increasing their risk for other complications like hemorrhage or infection. And although the 1849 statute did not restrict counseling about abortion, one participant described how their institution's conservative interpretation of the law had led to constraints above and beyond the provision of abortion care itself. The guidance that we were given in our system was that we were not allowed to provide any written information about obtaining termination. Strengths of our study include participation of OBGYNs from a diversity of state regions and clinical settings, including religiously affiliated hospitals. We also collected our data before the December 2023 judicial ruling that returned abortion access to some Wisconsin hospitals and health systems, which reduces the risk of retrospective bias. Our study is limited by potential selection bias, as physicians in our sample may have had stronger views on abortion restrictions than those who declined or did not answer our invitations to participate. In conclusion, study participants described far-reaching outcomes of the DAB's decision on the provision of pregnancy-related healthcare in Wisconsin. Specifically, the threat of criminalization posed by the 1849 law led to uncertainty and confusions for OBGYNs and substandard, delayed, and fragmented care for patients, often resulting in totally disparate clinical care for patients facing the same pregnancy complication. Study participants felt that this conservative and inconsistent interpretation of abortion restrictions often protected institutions at the expense of patients and physicians, and that this compounded confusion, harms, and risks for everybody involved. And finally, our findings demonstrate that institutions have the potential to be either barriers or facilitators in the provision of healthcare, even while functioning under the same state-level restrictions. When facing statewide and/or institutional abortion restrictions, we argue that hospitals and health systems must, at minimum, provide clear clinical guidance, meaningful legal resources, and robust referral processes to protect the well-being of both patients and physicians. Just like to acknowledge first our study participants, my co-investigators, Corinne Hale, Laura Jacques, Eliza Bennett, Jenny Higgins, the UW Collaborative for Reproductive Equity, CORE, our research office here in the department, and the Anonymous Family Foundation that funded the study. Thank you.
That was a great presentation. I was wondering if, as you mentioned, the study participants that perhaps did not answer the survey, like, do you have any demographic information or information on them to see maybe why they didn't participate, to see if there was some bias to the responses, or if that's, or it's a more even playing field and truly this is, the way it is?
Yeah, thank you. That's a great question. We don't have demographic information collected on folks who we approached to participate in our study in an interview. I mean, interviews were on average 45 to 60 minutes in length. There was no additional survey. To be honest, we had very little trouble recruiting for this study. People we approached, even those, whom investigators did not have a personal connection to, were very willing or eager even to participate in an interview. And I think many felt it to be helpful and even cathartic in processing what their experiences had been and were, because we conducted this during the ban time.
Thank you, Dr. Cutler. I was wondering if there were any differential themes that emerged with the participants between the rural and the urban settings, especially if you cross-reference those with any of those maternal deserts that you had talked about at the beginning of your presentation.
Yeah, thank you. I mean, thinking back to the raw data and the codes, and I do think it would be safe to say that participants from the more rural areas in our state certainly had much less support from their institutions in terms of legal guidance, legal teams, assurances about what it might look like if they were to be charged under this criminal statute, and how they would fare. The themes that came up in those interviews certainly centered around kind of a reliance on the bigger tertiary centers to not only be willing to take their patients when necessary, but also to be kind of leading the way in what care was thought to be legally permissible to be providing under the statute. Those are some things that come to mind. Thanks so much.
Okay, good morning. Those of you who don't know me, I'm Ian Bird. I'm a member of the Reproductive Sciences Division. Been here a fair time, 30 years. And just a little bit long. And we're going to shift gears now and go to a study at the much more basic level that does actually have direct therapy implications. And the presenter today is Luca Clemente, who is he did his PhD while he was in the Department of OB-GYN. Now he's a postdoc, was funded on the Integrated Program Endocrinology Training Grant. And I'll let him introduce his own work and title, but if you want to kind of understand where we're going, it's this. When is an endothelial cell not an endothelial cell? And the answer is when it's preeclamptic. Okay.
Let's see how to start this. Okay, so today, if you were to ask researchers in the field of preeclampsia what the cause of preeclampsia is, they would say it's complicated and we really don't understand it. But there was a time just not long ago when prominent researchers were pretty confident that they did have the answer. In a review from 2011 from the Harvard Medical School, the authors concluded with preeclampsia as a disease which begins in the placenta and ends at the maternal endothelium. As reviewed here, evidence suggests that the disease is attributable to anti-angiogenic factors, soluble FLT1 and soluble endoglin released by an abnormal placenta. But it wasn't too long before the problems with the mainstream consensus became apparent. In 2015, a Canadian research team identified a minimum of 3 distinct subtypes of PE, each with their own etiology and gene expression profile. The first one they called classical, and that pretty much corresponded to the dominant paradigm at the time. But they discovered a second one characterized by elevated expression of immune response genes that they called immunological PE. And they identified a third type they called maternal PE, in which the placental gene expression and anatomy were essentially normal, but the severity of the pathology was correlated with pre-existing risk factors. So, and the many risk factors for preeclampsia imply multiple causes. So things like cardiovascular disease we would expect, but there are some unusual ones like sleep disorders, problems with the oral and intestinal microbiomes, autoimmune disorders like rheumatoid arthritis, and even COVID. So viral infection is a risk factor. So if we go back to the first slide, we started out by asking the wrong question. There are multiple causes of preeclampsia. It doesn't necessarily begin in the placenta. It's not necessarily attributable to anti-angiogenic factors, and the placenta isn't necessarily abnormal. But how about that one I skipped? Does preeclampsia really end at the maternal endothelium? Well, just 2 years after that review came out, Dr. Bird's laboratory published a study that looked at the vasodilation capacity of intact endothelium from the umbilical vein. So now we're talking about the fetal side of the placenta. When the vessels from healthy pregnancies were treated with a physiological agonist like ATP, there was an immediate spike in the level of free intercellular calcium, followed by sustained calcium bursts, which are necessary to maintain pregnancy-adapted vasodilation. And you see this robust synthesis of nitric oxide on the left there. So on the right, in endothelium from preeclamptic cords, the initial response to ATP was similar, but you lose the sustained calcium bursts, and nitric oxide production is significantly impaired. And it's also since the time of that Harvard review, evidence has accumulated that TNF, IL-1 beta, and other cytokines that are known to be elevated in preeclampsia are also elevated in umbilical cord blood. And children of preeclamptic pregnancies are at a greater risk for a whole host of diseases, again, some you wouldn't expect. And the authors of a 2024 review described the offspring of preeclamptic pregnancies as possessing enduring endothelial, vascular, and immune dysfunction. So preeclampsia definitely does not end at the maternal endothelium. So this is where our current project comes in. So in order to see how cytokines known to be elevated in preeclampsia affect gene expression in human umbilical vein endothelial cells, HUVEC, we cultured 4 identical samples of healthy HUVEC pooled from 5 umbilical cords and treated the cells for 20 hours with TNF, IL-1 beta, interferon gamma, or vehicle. And we then sent the samples to the Gene Expression Center where they were subjected to single-cell RNA sequencing. And this enabled us to get the sequence of every mRNA transcript in every single cell in each of the treatment groups. So we were able to quantify specific effects of each cytokine on gene expression and identify possible subpopulations of cells that may respond in unique ways. And since we have a transcriptomic profile for every cell in each treatment group, we can now sort them spatially by degree of similarity, and this results in the formation of clusters. The colors that are assigned by the Partec Flow software are arbitrary, but you can see that the cells sorted almost exclusively by treatment group. The samples were very homogeneous. This was unexpected since endothelial cells are known to normally exhibit significant heterogeneity, but these were just very uniform. So cluster 1 corresponded to the control cells. Cluster 3 corresponded to the interferon gamma treated cells. And then you have this clump of TNF and IL-1 beta treated cells together, which formed cluster 2. So this is the master heat map for the whole experiment. So every row represents an individual cell, and every column represents a specific gene. So when you look at this, it's pretty easy to see why there were only 3 clusters and why the TNF and IL-1 treated cells were put into a single cluster. And it's also interesting that the TNF and IL-1 beta treated cells, you see this general increase in gene transcription overall, the red color. And then in the interferon gamma group, you see this general suppression of transcription overall. So the first thing we wanted to do in our analysis is look at what happens to known genes for known endothelial cell markers. Now these are genes for proteins that define what an endothelial cell is, right? So naturally they're expressed robustly in the control cells, but you can see that in TNF and IL-1 beta in cluster 2 significantly reduced the expression of these genes. And I've highlighted 3 of the genes that are critical for barrier maintenance, vasodilation, and angiogenesis, respectively. A suppression of these genes suggests that TNF and IL-1 steer these cells away from their classical phenotype and contribute directly to endothelial dysfunction. Okay, so we wanted to, if they're moving away from their classical endothelial phenotype, what are they moving toward? So when we looked at the overall transcriptome, we noticed that chemokine genes were robustly expressed. And chemokines are secreted molecules that attract immune cells to the site of inflammation. And when umbilical vein endothelial cells are exposed to TNF or IL-1, and in some cases interferon gamma, transcription of chemokine genes goes way up. So in each of these figures, the first column, the blue one, would be the control cells. The second one, cluster 2, is the TNF and IL-1, and then the third column, the yellow, is the interferon gamma treated cells. And we don't need to go over every single one of these. The point is that there's different types of chemokines, and the CXCL chemokines are strong chemoattractants for neutrophils, which are the most common type of white blood cell, and they're known to be elevated in preeclampsia. Whereas the CCL chemokines and CX3CL1 attract a wide variety of immune cells. And that one of those, the fourth one over there, CCL20, is interesting in particular because it's a potent attractor for highly pro-inflammatory Th17 cells, and which are overactive in preeclampsia. And CCL20 is also being considered as a possible clinical biomarker. So we also looked at attachment molecules, which were upregulated, particularly in the TNF and IL-1 treated group. there was a dramatic upregulation of 3 critical attachment molecules, genes. CELI is the gene that encodes E-selectin, which initiates the rolling of immune cells across the endothelium. And then ICAM1 and VCAM1 stabilize adhesion, guide migration across the endothelial barrier, and amplify inflammation. So once the immune cells have been drawn to the endothelium and are securely attached, the endothelial cells can engage in crosstalk with bound immune cells through the use of co-stimulation molecules. So co-stimulation is a process in which particular signaling molecules on the surface of an endothelial cell bind to their corresponding receptors on the immune cell, or vice versa. And this process can alter the programming of both the immune cell and the endothelial cell. So depending on the relative concentration of these various molecules, you can get an immune response that is either suppressed or augmented. And the general pattern we see in the TNF and IL-1 treated cells of cluster 2 is pro-inflammatory. And I did just want to, one interesting thing, if you notice the genes for galectin-9 here and for the light receptor, those are 2 where you see an increase from the interferon gamma treated group. Those are both generally inhibitory to the immune response. So in conclusion, there are distinct placental subtypes of preeclampsia, but all exhibit endothelial dysfunction resulting in hypertension and proteinuria. Elevated uteroplacental cytokines do cross into the fetal vasculature. TNF and IL-1 beta in turn shift the fetal endothelial transcriptome away from vasodilatory and barrier functions and toward an immunomodulatory phenotype. This process in utero appears to permanently alter endothelial and/or immune responses to subsequent stressors, leaving both mother and child at higher risk for an array of diseases later in life. And finally, as key contributors to endothelial dysfunction are identified, it may be possible to preserve pregnancy-adapted vasodilation and barrier function by direct immunotherapeutic targeting of the endothelium. Okay, these are the people I would like to thank, and I'm ready to take questions now.
So it's really beautiful work. Have you, or are you planning on looking at immune endothelial interactions after you did the cells?
Money dependent, we would like to do co-culturing because this is only half the story. So it would be really good to have data where we co-culture with immune cells and determine how the transcriptome of each is altered. Because I feel like more happened. We're only getting the first part, and we need to get the what the immune is doing. PBMCs. Yeah.
This is really exciting work, really nice. Have you, or are you able to also look at like the maternal decidua and see if any of these chemokines and cytokines are being released, and what's the inflammatory process there as well, as we see it, because it's obviously maternal and fetal.
Yeah, no,
endothelial cells.
we haven't, but that wouldn't surprise me. In fact, I'd be really surprised if it wasn't happening. Yeah.